I can't believe they call this ecstasy. This is not fun. But some people also reach this wonderful state of relaxation in their body that they haven't felt for a long time too. And this is such a radical departure from the way that we do trauma-focused therapy.
All right, welcome everybody. This is David sitting in a lovely colored room with Rachel Yehuda. How are you doing today, Rachel?
Terrific. Thank you for inviting me.
Yeah, no, it's wonderful. We're in Jerusalem, a really special place for our world and for us. And we've got some really important things to talk about. Not boring stuff, but really important things around how the world of medicine, trauma treatment is changing and the potential of psychedelics. So, good place to start is, in a nutshell, what drew you to psychedelic-assisted therapy? And how hard was it for you to, in a sense, join the movement, if you want to call it that? Or what would you call it that you've joined?
Well, those are good questions. I didn't seek out an interest in psychedelics. Psychedelics kind of found me. I was introduced to Rick Doblin many years ago, actually at the Burning Man Festival. And he basically asked me what I thought about giving psychedelics to veterans with PTSD. At that time, they had just completed phase 2 trials. And I'm a traditional neuroscientist, and I knew the literature about MDMA and other psychedelics, potential neurotoxicity, things like that. So I actually thought it was maybe not such a good idea to give people a mind-altering drug. But I was open to learning. He asked me if I was open to learning more about psychedelic-assisted therapy, and there was going to be a training in Israel a few months later that he invited me to, and I went. And during the training, which was in a beautiful place, Neve Shalom, with Israeli and Palestinian therapists, Michael and Annie Midhofer ran the training, and it wasn't what I expected. And I began to understand that really the idea isn't to directly affect the brain with a drug, but rather to create an opening and an opportunity for people to really explore very difficult material. So that's what drew me in, because I really understood the potential.
Yeah, and it's important that when we're thinking about the brain, that yes, there's complicated theories and biomarkers and receptors and synapses and fMRIs, but at the end of the day, it's the human being and what they do with their life when the medicine works. So what have you found around psychotherapy? How important is that for you to combine with these psychedelic compounds, MDMA, ketamine, psilocybin, whatever it might be?
Well, to me, our experience has been that the opportunity to be able to talk about material that has just not been accessible before is what turns people around, or at least the combat veterans that we have studied in the VA. And they'll tell you that.
Yeah.
What goes on during the medicine session itself, or the dosing session, or the journey, whatever you want to call it, can range from being very pleasant and feeling good in your body to being excruciating if very difficult material comes up, when many people have said, I can't believe they call this ecstasy. This is not fun. But some people also reach this wonderful state of relaxation in their body that they haven't felt for a long time too. But what they all talk about is that they're able to open up more and really find the things that need to be discussed. And this is such a radical departure from the way that we do trauma-focused therapy, quote-unquote, today, with another quote-unquote, our evidence-based treatments, which are the cognitive behavioral therapies for PTSD. Even before I met Rick Doblin or became interested in psychedelics, I was becoming very concerned that these therapies that are the gold standard approaches for PTSD just weren't delivering enough healing to enough people, that many people actually felt pretty traumatized by reliving their experiences in the directed way that is often required in these kinds of approaches, combat veterans. For civilians, I think that these approaches worked better. But the difference is that when you talk about combat, you're talking about a very specific kind of experience. Well, people have signed up to go. They were excited to go. They felt that they were doing something positive with their lives by going. They often did extremely positive things when they served their country, but they also weren't prepared for some of the exposures that they were going to have. They maybe never dealt with how their pre-deployment lives contributed to their wanting to be in combat, or how difficult it's been for them since they returned home. And when you have a directed approach which says, okay, tell me about your trauma. Oh, that firefight? Okay, why don't we review that particular event? That's very different than letting somebody be in a totally relaxed state and have different memories appear before them. And there were many sessions where, even though combat trauma was the trauma, it's not what came up in the medicine session. Stuff about childhood came up, or stuff about what's going on in the here and now, or incidences that were just really early wounds or attachment wounds, or things like that. So there's something really wonderful about being able to say, oh, that event was important, even if it may not be listed, and to have some 5 options of what counts. And then having the therapists be able to really work with why that's so important, why that is connected to something in combat. Many combat veterans come back and are wounded because of moral injury, which is a little bit different than, than the fear of the battle. They're connected, obviously. But a lot of people aren't prepared for the kind of decisions they have to make on the spot, and how much their survival instinct will kick in and contribute to them doing things that they might not have thought they would do or be capable of doing, or seeing things that really challenge their worldview of what they're doing there to begin with. So I think all those things are really complicated. And when you give somebody an open-ended opportunity to bring up the material and then talk about it, it might be more therapeutic than deciding in advance from a list the hierarchy of things that are from the most to the least traumatic, when it's very hard to measure what is the most to the least traumatic under many circumstances.
Yeah, it's really important what you're saying around, I guess, exposure therapy is one of the kind of frontline treatments we're using for trauma now. And it is exposing them to their kind of worst fears or most difficult experiences. But it's also prescribing it, whereas what you're saying about actually has helped them regulate their nervous system, be deeply relaxed, and then whatever comes up, maybe from their unconscious, from their childhood, memories, feelings, maybe connecting together different parts of their life, the therapist will help them to explore that, to kind of join the dots together and to kind of co-evolve meaning with it. So it's a more kind of creative, constructive.
Yes, you're exactly right. A lot of times the interventions that you make in a session or after it are exactly what you would be doing in cognitive behavioral therapy. The cognitive reframing, the Socratic questioning. I mean, knowing how to deliver those treatments is wonderful preparation for being a psychedelic therapist, because you have to do those things. These are really important ways that we get people to focus and reframe. But the big difference of you deciding that it's time to do this as the therapist versus the patient bringing it up and you following their lead, I think really makes the difference. So, there have been a lot of recent discussions about, should we use quote unquote evidence-based therapies in connection with psychedelics? And, my reaction to that is we already do. We just don't do it in this very rigid, structured way that people tend to do it, actually not even in clinical practice, but for research. And this is something that is very difficult to explain to people, that when you're trying to get evidence for a therapy, you have to study it in a much more rigid way than you're ever going to deliver it in clinical practice. You have to be able to completely be able to have measurable outcomes. You're going to have somebody be able to rate whether every therapist performed the therapy in the same way. And that's how we get the evidence, right? Usually we compare it to some other treatment. In the case of many of the evidence-based therapies for PTSD, they were compared to a waitlist control, which effectively is a group of people that are not receiving any therapy. So no wonder the therapy is better. But we shouldn't be taking this stuff so literally. All the things that any good therapist does in the context of any kind of PTSD therapy, certainly cognitive behavioral therapy, is a skill they're going to need to bring to bear at some point during doing this kind of work, I think.
Yeah, I think competent psychedelic therapists are going to need a lot of training, a lot of different skills in their toolbox, because there's just not one like golden magical modality. There's many.
Right. And the difference is that when you do this, for research or the way that the protocol is designed, a lot of things that come up that are not in the direct line of the trauma, quote unquote, that you're processing, a therapist might say, are you avoiding talking about the trauma by talking about your relationship right now? No. The trauma may be affecting the relationship, and you're now making some sort of connection between them.
The crazy shit could be kind of the vehicle through which trauma is expressing itself.
So it's not avoidance. So there's a rigidity that I think belongs in research. Don't get me wrong. I'm not criticizing any of the research that's been done. I think what's really very difficult is how to take all the gains that we've made from doing these kinds of careful studies and careful manuals and protocols and breaking the interventions down into their, smaller components. How do you bring that back in a treatment that basically is patient-driven? That's the only difference.
Well, I want to talk about that because, I follow you on social media and I love how outspoken you are, how straight and direct, how much you go into detail, and you love the science, you love the data, outcomes, in a sense, to prove that this has efficacy. But this is a but for me. I'm sick of randomized control trials.
Yes.
It costs hundreds of millions of dollars. We're doing them again and again. And in the real world, which you're talking about, Rachel, in the real world, people aren't that clean. We're messy. We've got all kinds of difficult stuff in our closets, different contraindications, different medications we're using.
Yeah.
So how can we just make these medicines work in the real world with a bit more pragmatism, a bit more openness?
So I think randomized clinical trials are important, but I don't think placebo-controlled trials are important for psychedelic studies. Nobody had a problem whatsoever adopting prolonged exposure or cognitive processing therapy as standards of care when they were compared to essentially waitlist controls. There was no blinding because you can't blind anything in psychotherapy. So both the therapist and the patient know what condition they're in, and somehow that's okay. But because these psychedelics are medications and they're drugs, people have felt a need to superimpose an inert placebo or sometimes a psychoactive placebo. And I think that takes us into territory where it's kind of fake. So to me, I do believe in randomization. I think it's really important. And even the psychotherapy studies had that. It's by chance what group you go into. Is blinding important? Maybe not quite as important. We have to think about that. Well, to me, what would be important is to compare any new treatment to what we're doing now clinically. Whether it is manualized cognitive behavioral therapy, which most people don't practice in that rigid way. You're a therapist. You use these therapies. Do you do session 1, session 2, session 3, session 4, session 5 in the way that somebody would be doing it if you follow a research manual?
No, it flows, and
It flows.
you make it up as we go along.
At work, but you're doing the thing, right? Yeah. You're definitely keeping people focused on what their fear is and confronting their fear and reframing their fear and engaging emotionally when they're too intellectual, or engaging more intellectual when they're too emotional. And those techniques are very useful to you. So I think that we have to just step back and really explain to the FDA, to regulators, to people who are conducting clinical trials, that if you have the elements of these approaches, which can be monitored by viewing tapes, and somebody has a checklist like, oh, cognitive reframing, we just did that. It's possible to do that, and giving people kind of a real clear idea about what to expect when a patient is in an altered state, and role play, what kind of interventions will or won't work, understanding that people are different. And something that really landed in one case, maybe really, you've been there when that's happened. And it was like, what happened? This worked so well 2 hours ago, because we're all different. And so, again, just finding a way to compare what we want to do with what we do now, and say, is it better, much better, even if it's the same. It's another option for people.
Yeah, and when you look at the outcomes data from the MAPS, like us, trials, phase 2, phase 3, it's phenomenal compared to first-line treatments that we've had for the last few decades. I was one of the people that thought, this is going to be approved. There's no way that the FDA will say no to this. And then, 6 months prior to the decision, lots of kind of things came up, and there was the AdCom, the committee where a lot of critiques were thrown in. So I was surprised and angry and disappointed, to be honest. And I'm going to try and be diplomatic here and neutral, but no, these are people's lives at risk. I want to give my clients the best that I can give them, and often that might be MDMA or ketamine-assisted therapy. How did you take that kind of lack of an admission and approval by the FDA for Lycos MDMA-assisted therapy?
I was disappointed by it. I had built an entire research center on the assumption that the FDA would approve this. We have many protocols that we're still going to go forward and do, testing MDMA and psilocybin and lots of other psychedelics. And initially, I thought, oh gosh, this isn't fair. But as I started to really try to understand what some of the reservations had been, a few good points were made. I don't think that they necessarily rose to the level of deal breaker, but I think that things were going so fast, and there had been so much hype, and there had been so much buzz around this as if it was a done deal, that I think somebody just hit a pause button. They didn't say, no, this is not an approved therapy. That's not what happened, right? It feels that way, but that is not what happened. You just said, well, if somebody is calling the data into question, maybe we should review those data. If somebody's calling into question the psychotherapeutic approach, maybe that should be reviewed. And again, it's a tough ask for the FDA that regulates drugs to think about psychotherapy. Maybe it just needed to have been minimized all along, meaning that you teach people how to work with this drug like any other, without this insistence that the psychotherapy has to be done in exactly a certain way. Although once people do take the training that I took, you understand that this is exactly the way, right? That there isn't really a different way to do it. But, in clinical work, we try a lot. We try out lots of things, and all of that's okay. So I think what's really good is that people did not think that MDMA is not an effective therapy, or that they did not think that it was dangerous. But in retrospect, maybe some of the decisions that went into the design or the data presentation could have been stronger. It might have all worked out, except that you had all these people come and complain and claim that they were hurt. And you can't just ignore those voices. You have to say, okay, let me pause and really understand what's happening here, because we don't want to do harm. The system's not perfect around that. And yes, there's a great need. So you're absolutely right that you have to weigh that against how many people are not getting adequate therapy that really need it. But it's a tough call. So yes, I was very disappointed. I wish that there would have been another outcome. But from a personal perspective, we're just going to keep going, because I really do think that, especially for veterans, but not just for veterans, this kind of fits what they need. It really works with all of the ambiguity and all of the kind of lack of clarity around, I like to say about the combat trauma that it's the best of times and the worst of times. And, victims of interpersonal violence just don't say that. They just don't.
Yeah.
So obviously, you want to find an approach that really honors that, because you definitely want to keep the parts that you're proud of. You don't want to throw away all of it. You just want to be able to live with the stuff that is really, really wreaking havoc inside of you.
And working with veterans in particular, Rachel, that's a big part of what you're doing, at the Bronx VA. And that's probably the best place for veterans to get this treatment, because they're working with folks that get the culture, that maybe a part of the culture. What are some of your experiences, or your clients' experiences at the VA, veterans working there? And what are some of the things you're researching?
I think that the veterans that we studied were very grateful that they could have this treatment in the context of the VA. They knew the providers. In many cases, they had been working with our group, with our therapists, for many, many years. So I've always had a very interesting program. I've been director of mental health at the Bronx VA. Before that, I was the director of the PTSD program. And somehow, most of the people that I guess I hired as clinical staff were very interested in facilitating the research. And before psychedelics, my research interest was in trying to predict, let's say, responders from non-responders to any therapy. How do I know this is going to work? And for whom will it work? And what does it look like when it does work? And what does it look like when it doesn't work? And so fortunately, the caliber of clinicians that we had at the VA in our program was people that were really curious about that too. So as they became very curious and really knowledgeable about psychedelic work, we were able to embed our study in a clinic. It was so organic. So you could have a patient, and then all of a sudden this opportunity comes up and you say, there's this study, I think she'd be a good candidate. Are you interested? Can I tell you more about it? We didn't really have to ask too many patients. The minute we began advertising, people were knocking down our doors. But then they can continue afterwards. And that's also the part we don't talk about enough in our field, which is that even if you get quite a bit better after psychedelic therapy, if you have a complex trauma, you need to talk about it a lot. But the difference is you're going to approach it in a much different way. It's going to really mean something. You're not going through the motions. You understand what it means to do the work. You understand what the goal is. A lot of people said to us, oh, now I understand what all those things were in prolonged exposure and cognitive processing therapy. Now I get what you're trying to do. So
They're seeing it from the other side.
yes, they're seeing it from the perspective of, yes, you can make a pivot. You are not as entrenched as you think. You can have a different view of your symptoms, because instead of seeing them as damage, I'm broken now, you see that you just haven't really completely shed your survival skills. Those things that you developed so that you could stay alive in the field aren't serving you that well right now. That doesn't mean you're broken. It just means that just as you adapted to combat, you have to readapt now by giving up some of those things. Even though it's hard to give up something that you know saved your life, even if it's expensive. And so that's a different reframing than how we tell people about their symptoms. Your symptoms are reflecting your damage in the amygdala. No, the amygdala's not damaged. It's just still frightened if it's still overactive. The idea isn't find the off switch on your brain. It's tend to your emotions so that they're not triggering the fear centers.
Hearing you talk, Rachel, it sounds like there's a positive feedback loop when people get better. And just like when they don't get better, there's a negative feedback loop. On one side, we've got our brain structures and mechanisms and what's happening there. And then we've got a more kind of humanistic, behavioral, relational, emotional, psychological, just lived experience. And psychedelics, affect the brain structure, but also looking at integration moving forward after the dosing session, there's neuroplasticity, but there's also, I think, relational plasticity, emotional plasticity, somatic plasticity. People feel different. They remember things differently. They have a new sense of purpose, conviction, and also giving themselves permission to feel emotions in a different way. And it's a self-reinforcing piece here. So that, I think, sends signals to the brain to go, yes, keep going, keep going. You're on the right track here. And then the person says, okay, great. So therefore I'm going to go and do something that was a bit scary, but I feel I can do it now. Or I'm going to go back to therapy. I'm going to, do something in a real physical way that reinforces the signals that the brain's sending and vice versa. That's how I'm starting to see this work, is this kind of positive feedback loop that can, eventually just make life feel different for people.
Yeah, I agree with that. I think that's a really good framing. What people usually find, I think you don't need psychedelics to find this. Let me be very clear. I think psychedelics make it go faster because it's such a profound experience. But if they can start to go easier on themselves, recruit self-compassion, sort of reframe their shame and their guilt, find empathy for self, kind of understand that people in their lives are really there for them, in terms of being able to recruit more social support. I mean, a lot of veterans, they don't not want social support. They're actually concerned for their loved one. They don't want their stuff to spill into someone else's day. And so they kind of isolate. They think that that they're sparing someone. A lot of times people feel about, maybe it's better off if I'm not alive. Call it suicidal thoughts or things like that. Maybe I'm too much of a burden on people that I love. Maybe, yeah, they'll be real sad at first, of course. But in the long run, they don't have to worry about me. I won't be a burden. They'll be free. So again, how do you change that paradigm? After a psychedelic journey, a lot of times somebody can emerge and say, no, that's not it. I belong here. I'm part of the earth. I'm part of the world. You feel like you're as integral to your environment as a tree or a flower. You belong here just like everything else in the world belongs here. And you just develop a different thing. That doesn't mean you don't have to work on your relationship. It doesn't mean you don't have to navigate the things that your symptoms require of other people that might be affecting them adversely. It doesn't mean you don't have to do that work. You certainly do have to do that work. Because you're coming at it from a different perspective where you're beginning to maybe see it from their eyes, that they love you and they want to help you, and just maybe let them a little bit more, maybe let them in a little bit more. And you stop trying to protect them and stop trying to control everything. Because that's the problem to begin with. You think that you have some control over things that you didn't have any control over. And then when it all went to hell, you think, well, why didn't I do a better job? And it wasn't you, because trauma is not your fault. You can't control everything. And it's perhaps the biggest lesson that many trauma survivors have to really internalize. They have to sort of give into kind of this higher power of not being in control. Because being in control um, is very important to people. And it's easier to say, I was in control, but I did a bad job. Oops. Than, you know what, I was never in control. That's a lot harder for people to contend with.
Yeah. And I think magic aspect of psychedelic therapy and medicine is the compassion, the forgiveness, the acceptance. And that's why a lot of modalities have acceptance and commitment therapy built into it. Because there's some acceptance about the past, about the lack of an ability to control the future, and compassion for, the way that life has been, and to move forward. And particularly around suicidality, there's a sense that I can't change the past. I'm broken. I've tried every drug there is, tried all the medicines, all the therapies. I'm still feeling terrible. I'm broken. There's nothing else for me. I think it's for folks like that psychedelic-assisted therapy could, offer something different because of the way that it works, because of how it can kind of clear out some of that emotional baggage, or just bring it up with love and compassion and acceptance.
Yeah, I mean, it's such an unfortunate byproduct of the way that we have conceptualized the biology of trauma for people to come out thinking that they're broken. Trauma requires so much adaptation. Yeah, broken, you've just had to adapt in a very jarring way. And now you have to adapt again. Because that is what's required. It's not that your capacity for adaptation is broken. It's just that it's really hard.
Yeah. I want to jump into a subject about Mount Sinai. So I don't know if you know this about it, but both my kids were born at Mount Sinai Hospital.
Yep.
Right? I also used to work there. Did you know that? I was a social worker in the inpatient psychiatry when I first came to America from, where was I from? I guess I was from Israel, actually. Yeah, I was in Israel and England prior to that. I worked on 6 South and Madison 5 at Mount Sinai. I learned a lot there because it's, really Upper East Side, Manhattan. You got the best of both worlds. We had billionaires coming into the hospital who had lost all their money, very suicidal, and we had people living on the streets of Manhattan. So I learned a lot there. You've been there a long time at Mount Sinai.
Yes.
And you very recently had the privilege of opening and expanding the Parsons Research Center for Psychedelic Healing at Mount Sinai. So could you tell us a bit about what your work is there and what the plans are for the future there?
Well, with a lot of gratitude to Father Renee Parsons, this really transformational gift happened after the FDA decided to not approve MDMA-assisted psychotherapy. And many of us were at a crossroads because as hard as it had been until that point, it now felt like it was going to be possible. And so the question is, do you say, gosh, I really tried. I put in a good 3-4 years, raised money, set up research projects, but what can I do? The FDA said, not yet. Or do you say, this is the moment to double down? This is the moment to really go guns blazing into turbocharge whatever plans you had for clinical trials and collecting data. And so I spoke to Bob and Renee about this, and to my great relief and gratitude, they saw the importance of really doing this. And so we were able to build a facility that has 6 treatment rooms in group space and really beautiful setting on 112th and Broadway. And it's a fantastic research facility. We can monitor people, collect data, and the data are important. There's no shortcut here. You have to get data. I think one of the things that has been problematic in our field is that it has almost felt like the clinical trials have been pro forma to people. Like, oh yeah, we know this works. I guess they just want to see a study. No, that's not how it goes. How it goes is you think something might work, and then you prove it, right? And if you don't prove it, or you didn't prove it yet, you have to try again to prove it, and look at why what you did wasn't convincing enough, and how you can maybe do it again in this way, in a manner that will reduce some of the questions that were raised by how you did it before. So we were very committed to gathering the data that would really be trustworthy data, including biologic mechanistic data, to go with our clinical trials. And now we have a place where we can do this work. We're going to be running a lot of different trials. We're at really final stages of approval for some of them. What people don't understand is that it's a big waiting game. You're waiting for the DEA and the FDA, and you're waiting for a lot of different steps to happen to do this research. But once you have everything lined up to go, I can tell you that there's an enormous amount of interest. People want to be participants in these trials. They want to try this healing. They want to do it in the hands of trusted people in a trusted institution. And so we're very excited about the fact that we're going to now be able to do this for at least a few more years.
That's beautiful. And what psychedelic medicines compounds are you hoping to use, or have you applied to get approval to use?
Well, we're still very interested in MDMA. We're interested in psilocybin. We're interested in 5-MeO-DMT, and we're interested in ketamine. We're actually doing the first trial in our new space is actually a very terrific project comparing ketamine-assisted psychotherapy, CAP, against the ketamine administered the usual way in a ketamine clinic.
Intravenous.
Yes, and so we're randomizing people to either come to our center and have CAP or go to the infusion suite of Mount Sinai and just have regular ketamine. And our hypothesis is that people that get the ketamine-assisted psychotherapy will have more durable gains. They won't feel a need for more ketamine. They may also experience greater healing because they're going to have the opportunity to talk about the insights or the experience of the drug. And this is a way of using ketamine, not just as, fixing something neurochemical that may be altered or broken or need to be chemically ingested, but a way to use the subjective qualities of dissociating or of having an out-of-body experience. And if somebody says, so what would that mean for you that you saw that spaceship in the sky, What was that about for you? And somebody might have a lot of interesting things to say about that. And again, arrive at an insight that will give it a little more flavor. And we're excited because this is in depression that we're doing this. And the jury has always been out about how much psychotherapy is required for depression. In PTSD, it's been more understood. That trauma processing is part of it. So again, we're excited. We're going to be doing some mechanism of action studies. I'm trying to block the effects of psilocybin with serotonergic agents, just to see what really happens, kind of the classic neurochemistry studies. And going to do group and couples work. So we're very excited.
Oh, that's great. In groups, couples.
Yep.
Phenomenal. Wow, so you've really got a playground here to find out some new data.
Yeah.
All right, well, before we wrap up, Rachel, was there anything else that you wanted to talk about that's top of your mind at the moment? No, it's been great.
Thank you.
Yeah, thank you so much, Rachel, for all your work over the years. And yeah, best of luck with everything you're doing.
Thanks for inviting me.
Yes.
Thanks again for watching, and thanks to our sponsor, Marpa Minds, a network of next generation mental health clinics offering Spravato and ketamine treatment for depression. Go to marpaminds.com for more information. Okay, I'm David Rabkin. Thanks so much for showing up. Until the next time, bye-bye.